Thank you for the beautiful introduction. This remember me that I'm getting older, you know, too many things. Good. Okay. So when we work on below the knee, one of the key points is obviously to improve the blood flow at the level of the ulcer and stimulate and facilitate the healing of the ulcer. There are a lot of debates since many years ago how we can do that one, because obviously many times we have a very complex situation where maybe there is only a single vessel bringing the blood flow to the foot, or maybe there are just few collaterals. One of the concepts that we are following is the angiosome. There are still a debate because there are some physicians that are in favor of the angiosome strategy or concept. There are other physicians that are not following the angiosome. Obviously, this is not a must or something that we have to follow in every case, but we must be a little bit more flexible. I think all of you are familiar with the angiosome that was introduced in the late 90s for plastic surgery, to define, the location of the lesion, the structure, the muscle, and the vessels. And in 2006, this was adapted for the vascular purposes. And then we evaluate, the different areas in the foot. Each angiosome is correlated to a main branch vessel. And in the foot, we have 6 angiosomes. 3 are for the plantar foot, correlated to the posterior tibial artery. Then we have 2 in the ankle and the rear foot that are connected to the peroneal artery, and 1 in the dorsum of the foot that is related to the anterior tibial artery. Obviously, there are also some connection between the angiosomes, and these are made by the choke vessels. In a normal condition, these are small branches that are not very important, for the perfusion of the tissue. But in those conditions where we have a disease, and there is a disease in the main branch or the main artery, they play an important role because they make some collateralization of the flow, improving the blood in the disease area. One of the big questions that we have is every time we are performing a revascularization is how many vessels we have to reopen or we need, to keep the foot alive. And also the other question is when to stop. We know that it's easy to understand that if we have a single vessel enough, this is obviously much better than no vessels, but also the 3 vessels can be better than 2 vessels. But sometimes this is not the ideal situation because that we are working for a long period, to reopen a vessel, then we decide to open a second one, and then everything collapses and we have to restart again. So this is something that we have to look with a lot of attention. Another discussion point is if we need or it's preferable to have a direct revascularization, or we can also use a non-direct revascularization through some collaterals. When we have a direct revascularization, this means that there is a direct flow coming from a single main artery directly to the area where the location of the disease is located. For example, if we have a lesion at the level of the dorsal foot, we can work and we can open the blood flow directly from the anterior tibial artery. If we are going for a non-direct revascularization, we have to work to some collaterals, or maybe we can go to another main branch to bring a reperfusion in a retrograde fashion. But it's something definitely that we have to analyze every time during the procedure. This is an interesting paper that was published a couple of years ago by Roberto Ferraresi regarding the IFU of the foot angiosome. And there are some important concepts in my opinion. Obviously, he reported that many articles demonstrated and stressed the concept of the angiosome when we perform the reperfusion. But there is something that we have to keep in mind, that sometimes in our daily practice, we are not able to follow the angiosome concept, because maybe the vessels are extremely diseased, there is no possibility to reopen our target, and we have to think about other strategy. And then many times, this is more than almost 30% of the condition, the words are spread by 2 angiosomes. And then it's a little bit more complicated situation because obviously we are not more targeting a single vessel, but we have to target more than 1 vessel. And this to me is a little bit more complicated in a normal condition. This a group of Chinese physicians made a retrospective evaluation of more than 100 patients regarding direct flow versus non-direct flow. You can see here that 1 year post-treatment outcome was pretty straightforward regarding the direct revascularization in terms of healing rate, 70% versus 34%, but also the time of healing, because remember, this is also something very important. You see here 7 months versus 10 months. So all this stress the concept that we have to work more and put a lot of effort to perform a direct revascularization. This is the Kaplan-Meier evaluation of the healing rate also after 1 year. You see the big gap between the two lines in favor of the direct revascularization. There's also something interesting regarding a sub-analysis of the direct revascularization. They reported single vessel or multiple vessel direct flow. And you see that it is pretty clear to understand and simple to understand that if we have more than one vessel, this can improve the healing rate and also the time of healing. So very important, if we can open more than one vessel, this is much better, especially for extremely or complex situation. Last year, a nice review was published with more than 900 patients from 9 different studies. And you see that, again, we have a direct revascularization and non-direct revascularization. Not a big gap in terms of number between the two techniques. That stresses the concept that also the non-direct revascularization is something that we can use in our practice. They reported the amputation-free survival that was a little bit in favor for the direct revascularization if you compare to the other technique. And regarding the time of wound healing, they reported no differences, they were not related to the direct or non-direct revascularization. So something that is interesting to keep in our mind. This was a paper published several years ago regarding the long-term outcome regarding the different techniques to reperfuse the foot. And you see again, the two techniques were put in comparison. And this is the amputation-free survival. And also after a long-term follow-up, because they evaluate up to 4 years follow-up, you see there is always an advantage if we regarding the direct revascularization versus the non-direct revascularization. Obviously, all of this beautiful data, beautiful information must be transferred to our daily practice. How we can do that? The first important point, in my opinion, is just to check the anatomy. You must be very familiar with the main branches, but also with the collaterals, for the whole perfusion of the foot. It's very important also to have a multidisciplinary approach to the patient and to the lesion, because then you have to define how, aggressive you must be. If you have just to open a single vessel, or you need more vessel because there is no other option for the patient. Once you define all these key elements, you have to look to the lesion, where it is located, the angiosome, if it is just one, or there are 2 angiosomes involved, and then you can define your strategy according to the vascularization. This is an interesting paper regarding the evaluation of the perfusion, because we know that when we perform a direct strategy or a collateral revascularization, what is important is to understand if what we are doing can improve the amount of blood at the level of the lesion. And perfusion is the method that can help us, to understand if we did a good job or not. This is what they evaluated, putting in evaluation the direct angiosome versus the indirect revascularization. And you see that there is always an advantage, so an increase in terms of perfusion for the direct revascularization. They also made a sub-evaluation regarding the indirect revascularization with a small number of collaterals or larger number of collaterals. And obviously you can see that when there are more collaterals patent or present, this gave a tremendous improvement in terms of perfusion, similar to what was for a direct flow. So this is something that we have to remember every time, to look to the foot and see how the distribution, not only of the main branch, but also the collaterals is. just to a simple case to show you, this was an healing ulcer of the foot. They see that there was no flow going down directly there from the posterior tibial vessel. So what we did is the reperfusion, recanalization in an antegrade fascium. This was the eye was showing in a nice flow. Dilatation and angioplasty. At that time also we used a dry-coated balloon, and this gave a straightforward blood flow to the lesion with a progressive healing. This is the image of the ulcer 30 days after the procedure. So in conclusion, we can affirm that the angiosome concept is valid. Obviously, it's not a must. We have to be very flexible in our decision-making process to understand the situation that obviously is different from each single patient, each single lesion. We have to finalize and define the anatomy in terms of flow, direct flow, main branches or collaterals, and sometimes it's also useful to combine a direct flow plus an indirect revascularization. So thank you for your attention.